So first of all, I thank Cybersight Orbis, especially Mr. Lawrence and Mr. Jonathan here for providing me this opportunity. So in this talk today, I will try to cover the basis of approach to a patient, a child with cataract, the pathogenesis and management basically. So we'll directly go into the topic. So as we all know, the incidence of pediatric cataract in the world over is 1 to 13 per 10,000 live births, and it affects 200,000 children blind. 200,000 children become blind due to bilateral cataract. And as we all know, cataract is a treatable cause for blindness, and early treatment ensures near normal life. And we are talking about children here, which means the life expectancy is going to be 60-70 years from the onset of the problem. So that is why this talk today is very important. So why pediatric cataract specifically? So as we all know, adult and pediatric cataracts differ in almost every possible way. As we know, a child is not a small adult. So pediatric cataracts are different in etiology, the age of onset, laterality matters in the way we manage, whether to operate or not arises, when to operate, who operates, whether to put intraocular lens implantation or not, the inflammatory response the children's eyes may be exposed to, the complications that are faced which may be lifelong, and the rehabilitation which follows. So in all these ways, pediatric cataracts are different as compared to adult cataracts. So this is the first question. I just wanted to know who is today registered and who is watching this lecture. This lecture will probably be of use to practicing pediatric ophthalmologists, general ophthalmologists who invariably get to manage children, of course, ophthalmology residents, and of course other interested optometrists also can benefit from this lecture. So the pathogenesis, as we come to pediatric cataracts are basically classified based on their morphological appearance and etiological presentation. So in morphology, the cataract arises due to arrest in the growth or some disturbance during the development of the lens. So depending on which position of the lens opacifies, the cataracts can be classified accordingly. And as we all know, that because of the structure of the lens, the more anterior the lens opacity is, the less vision threatening it is, and the vice versa. The more posterior and central, the more vision threatening the opacity becomes. So morphological classification, we see anterior polar, pyramidal and anterior subcapsular cataracts are common in children, and when it is posterior, it can be posterior subcapsular, posterior lenticonus. It can be associated with persistent fetal vasculature as part of a developmental abnormality, and Mittendorf's dots. All these cataracts are posterior. So these are some examples of anterior lens opacities. As we all know, the first one is the anterior polar cataract. The second one is anterior cataract, which are riders. It's more of peripheral. And the third one in the right corner is a blue dot cataracts, which sometimes in the center, but mostly it is in the anterior. Posterior cataracts can be posterior subcapsular opacity, as we see in the first one, a membranous cataract where the posterior capsule can be opacified for various reasons, and posterior lenticonus, as we see in the final picture. So these are more vision threatening because they are in the center and closer to the nodal point of the lens. And central cataracts, which we see more commonly, can be nuclear, lamellar, otherwise called zonular, cortical riders, sutural cataract, pulverulent cataracts, cerulean cataracts, aculiform or coralliform cataracts. So these are some examples of central cataracts, which depending on their density affect the vision and hence the need for management. The right side corner cataract is a total cataract. So etiologically, we saw morphologically how cataracts are classified in children. Etiological classification, when it comes to that, we divide them into bilateral presentation and unilateral cataracts. So bilateral, the commonest etiology is no cause, like idiopathic, which is up to 50% of the cataracts have no cause. The second commonest is congenital or developmental. Again, here cause is idiopathic. Hereditary or genetic can be second reason, and associated with inborn errors of metabolism and torch infection perinatally can be a cause of congenital bilateral developmental cataracts. Ocular anomalies like aniridia, anterior segment dysgenesis syndromes can also have bilateral cataracts as presentation at birth. And metabolic causes like Lowy syndrome and so many other syndromes which affect the general metabolism can also present with cataracts at birth. And steroid induced, obviously children are more prone for allergic conjunctivitis, and inadvertent chronic use of steroids either topically or systemically for children like nephrotic syndrome and other systemic conditions where steroid is indicated in children can present with cataracts at a little later age. And etiologically, for unilateral cataracts, a specific eye problem has to be first noticed. Trauma probably leads the picture, traumatic cataract in children. And secondly, it can be part of an anterior or a posterior segment anomaly, like corneal opacities, congenital opacities can present with cataract. Peters or Axenfeld anomalies, when they have unilateral presentation, can also present with cataracts. And commonest in this category can be persistent fecal vasculature, presenting with membranous type of cataract, which can be highly vascular also. And complicated cataract due to uveitis can be unilateral or sometimes bilateral. So when it comes to cataracts in children, as compared to adults, the clinical features may be a challenge. So children may not present with complaints as compared to adults who come with their own complaints. So we need, as parents and as doctors, to pick up the symptoms and signs which the child may not come complaining about. So what are the symptoms the child may present with? The parents may directly notice a white spot in the pupillary area. Commonly, diminution of vision. Very young babies, they may have does not recognize the mother's face or objects very close to face, etc. Unsteady eyes can be a presentation of congenital cataract. Deviation of squinting of the eyes and associated symptoms of the systemic disease, if present, can also be a symptom. And what will the signs be? Again, diminution of vision, less vision. As per age, we can check the vision and we can find out like poor fixation, roving eye movements, etc. We can see the lenticular opacity. Nystagmus can be present, strabismus can be present, and other ocular and systemic abnormalities can be present. So when it comes to management, so how do we manage? Do we need investigations in children? So cataracts as such do not really specifically need a battery of investigations. A thorough history to find out the cause, like whether it is a genetic cataract, was there a systemic steroid usage, is very important. A thorough ocular examination to see associated anomalies, a history of trauma or a telltale evidence in the eye of trauma. And in some cases, when you cannot see the posterior segment of the eye, an ultrasound biomicroscopy helps in case of total cataracts, and a good systemic evaluation. These are the maximum investigations probably that we would need before we decide on the next step. So this would be the next poll question. How do we manage these three situations? So So these three situations have all one thing in common. If you see the cataract in the first central picture, the central visual axis is relatively very clear. There are riders in the periphery, but central visual axis is clear. The right corner where you see the blue dot cataract, again, here we need information about the vision and other symptoms. So these three cataracts are typically non-vision threatening. So you can just observe. So in children, there is a role for specifically no treatment in some of these situations. So these cataracts are usually stationary. They do not progress. All we need to do is correct the associated possible refractive error, etc., amblyopia, etc., but need not go ahead and manage the cataract specifically. So then that is what? Operate or not to operate? Does this situation occur in children? Definitely. Why is this a question? So when do we face these kind of questions in a pediatric cataract situation? So no symptoms. Can there be cataract in children with no symptoms? Exactly. So like we just saw these three examples of cataracts where the children may not present with any symptoms. And bilateral symmetric cataract in a little younger child where there may still be no symptoms without any secondary effects like nystagmus, strabismus, anisometropia, when you're able to check the vision in a child, and if the visual acuity for near especially is N6 and distance is at least 6/12 in both eyes, you can observe the cataract, because when we operate a child for cataract, once and for all, we remove accommodation. So we have to be very conservative when it comes to providing clarity of vision. The aim of surgery for a pediatric cataract is to give clarity of vision, distance as well as near. So near vision, if it is good, despite having a slight subnormal distance vision, warrants probably a little conservative management, like we can wait and watch. And non-progressive, early steroid-induced cataracts may be non-progressive if we stop the steroid at the time, and we can observe these kind of cataracts. So in children, there is a role for not operating a cataract. And is there a role of non-surgical management? Is it possible? So this typically cataract is a little paracentral. It's affecting the visual axis centrally, but not fully covering the visual axis. The patient may have an associated exotropia with a -3 cylinder and a vision of 624 N8. So what do we do for this cataract? Do we go ahead and operate? So when cataract may be only one of the reason for a vision problem, we have like high anisometropia, strabismus, corneal opacity, macular pathology. So it is part of a multiple problem. So we can still wait by giving management for other problems, like you can give dilating drops if the opacity is a little paracentral, and of course glasses and patching. And then if vision improves and we still feel the cataract may also be contributing to the vision problem, we can operate at a later stage. So then we come to surgical management. So how do we decide and how do we manage a child with a cataract? So indications for early surgery. Whenever we talk about children and cataract, we want to know when to go ahead with surgery. So how do we decide? Total cataract. Of course, there is no controversy here. Total cataracts have to be operated as early as they present. And unilateral cataracts in a child is almost like an emergency. You have to operate as early as they present. Asymmetric cataracts behave similar to unilateral cataracts, and presence of secondary effects like nystagmus and strabismus mean there is always a sensory component involved and already vision is getting compromised. And symptoms, a school-going child with a vision worse than 6/18, a child with photophobia, all these warrant early surgery. So then early surgery, does it translate into early intraocular lens implantation? So when do we have this question of intraocular lens versus no intraocular lens implantation at the first sitting? So here the prime concern is the age of the child. The first foremost concern is age of the child when we plan cataract surgery with an intraocular implantation at the primary stage. So why age of the child? Because very young children, very young eyes, the biometry surprises are known to occur at expert's hand, and myopic shift is supposed to be rapid till the age of 24 months. So that is how age is significant when we plan intraocular lens implantation as a primary procedure. And laterality of the cataract, when you produce a child with a cataract and you operate and leave the child aphakic, you are producing a huge anisometropia. So we have to weigh the pros and cons of leaving a child aphakic versus the risks involved in primary intraocular lens implantation. Because visual rehabilitation for unilateral aphakia is very challenging. The diameter of the cornea is a criteria where when we have to consider intraocular lens implantation in infants as well as axial length. So these are the criteria we need to look into when we plan an intraocular lens as a primary procedure during the cataract extraction. So what are the surgical techniques that we have in our hand? So the commonest procedure we follow for pediatric cataracts is lens aspiration with a primary posterior capsular rhexis and anterior vitrectomy with an intraocular foldable lens implantation in the bag. Or if we do not plan an intraocular lens in the first sitting, then we can do a lensectomy with an anterior vitrectomy, either a pars plana approach or a limbal route, depending on your expertise and depending on this, probably the size of the eye and the development of the pars plana. So how to choose IOL in children? So this again is a challenge. So every step in a pediatric cataract management poses challenge. So what are the factors influencing intraocular lens power calculation? So the formula, what formula to choose from? The myopic shift, which keeps happening in young infants, the amount of shift proportionate to the age, the axial length and the keratometry measurement, and what we aim for, which is the target refraction. So all these influences IOL power calculation in children, especially less than 2 years of age. So this is the third question. What is the preferred IOL formula that if you are a practicing pediatric ophthalmologist, do you prefer? SRK2, SRKT or Hoffer-Q. These are the three common formulas used in children. So which one do you prefer? Questions? I don't know what. So as per literature, it says that any standard table you can choose from these three. We commonly choose SRK2 if the axial length is above 16 mm. So that is the criteria. Very young axial lengths, better to avoid intraocular lens implantation. So all these three formulas work well. It is a target refraction that you have to look into. And if you're planning both eye surgery, it is always a good advice to get a refraction done for the first eye before you plan the second surgery to have an idea about your biometry value. So what is a target refraction? So in a children compared to an adult, to enable a myopic shift, you aim always an undercorrection depending on the age. So there are various methods and various ways over the last 30-40 years of pediatric cataract surgery evolution. We have found certain guidelines which can help us choose the target refraction. So there is a rule of 7 for children above 2 years, where the age plus target hyperopia is the intraocular lens power. So if the age is 2, you add, to get a number of 7, you add plus 5. So similarly, to the sum should be 7. So you add the age and the target hyperopia. So you choose based on, this is a rough estimation which is in literature, described in literature. For infants, we have two major good studies, infant aphakia study and the Wilson et al. Study, where for less than 6 months, they prefer 3 to 7 diopters of hyperopia as the target refraction. And for 12 months, 0 to 3 diopters of hypermetropia. For IATS, 4 to 6 weeks, they aim for 8 diopters, and 6 weeks to 6 months, they aim for 6 diopters. Again, it is still controversial, but this is kind of a guideline which we try to follow. So what we follow in our institute is age above 4 years and 2 to 4 years, we aim an undercorrection of up to 10%, and age less than 2 years, about 20% undercorrection. So then you decided the formula of what to use. Now what is the choice of the IOL? So it's previously, when we started, it was a single or a multi-piece PMMA lens, polymethyl methacrylate rigid lenses were used, but now it is primarily totally replaced in children by hydrophobic acrylic single piece IOL if it is in the bag, and acrylic 3-piece IOL if it is in the sulcus. The prime importance should be, it should be safe to use, and it should be like once and for all for a long term, and optical diameter should be at least 10.5 to 12 millimeters. So that is the aim when we choose the IOL in children primarily. So then we go to the steps of surgery. So what are the steps, basic steps? So general anesthesia, of course, preferred. A scleral tunnel is advised till the age of at least 4 years because the corneal rigidity is very poor. And anterior capsulorhexis of at least 6 millimeters. A cortical aspiration is done. A posterior capsulorhexis is mandatory about 4 millimeters. A limited anterior vitrectomy. Now this is a little controversial, but we prefer to do anterior vitrectomy up to the age of 6 years. And in the bag IOL placement is mandatory as much as possible. And suturing of the corneal wound is preferred till 6 to 8 years of age. So this is how we do a scleral tunnel, and this is how we do a corneal tunnel. I'm sorry about the right side video. So we make a small conjunctival opening and cauterize those small bleeders. We measure approximately 3 millimeters and make a small corneal scleral tunnel and then enter the cornea. So this is preferred in children less than 4 years of age. Whereas a little older children, you can use a clear corneal entry. So we'll try to play the video in the end if possible. So the second most important step is the anterior capsule management. And I would say for a resident or somebody who's learning pediatric cataract surgery now, so this is the single most crucial step because this determines where you can actually place the IOL. Critical for IOL placement. It is a most challenging step in a pediatric cataract surgery, even more challenging than a posterior capsule management. It's because the anterior capsule in a child is very highly elastic. It has a tendency to run and there is no peripheral red glow. So how do we tackle these three issues? We can use a capsular forceps for a better grip. You always keep holding the rhexis when you do the rhexis. And a capsular staining always helps, so no need to worry about whether to stain or not. It is advisable to always stain the capsule. And a high molecular weight viscoelastic helps you keep the anterior capsule flat because in children the lens surface is a little more convex. So that is one of the reasons why there is a tendency to run. So with these three precautions, you can do a very good anterior capsulorhexis. So you make a side entry with a 15-degree blade. You put an air bubble. You dye the anterior capsule. You stain it with a trypan blue stain. You leave it only for half a minute. You do not at any cost want the posterior capsule to be stained. So you remove the stain comfortably. You make a small nick with a cystitome. And then you use a forceps, capsular forceps called Utrata forceps. It's a very comfortable instrument and you keep grasping and leaving the capsule as you go along, either clockwise or anti-clockwise as per your convenience. So the mastering the art of anterior capsulorhexis in a child using a Utrata forceps, probably you have learned most of the surgery. So the technique is to grasp and re-grasp. So the next step is the cortical aspiration. So once you have a very good rhexis, you can use the phaco probe or the inspiration aspiration cannula depending on the density of the cortex. And since there is only cortex, all you need to do is a cortical aspiration. You can use a bimanual technique or you can use a coaxial technique to remove the cortex. And here the tip is to remove every single piece of cortex because cortex inside the eye can throw up a good inflammatory response in very small children. So you have to make a note that cortex has to be fully aspirated. So the next question for the audience would be, how do you manage the posterior capsule? Do you do a primary posterior capsulorhexis with a forceps before IOL implantation? Do you do a posterior capsulotomy with a vitrector before IOL implantation? Do you do a posterior capsulotomy with a vitrector after IOL implantation, or do you do a pupillary capture? Q&A. And the Q&A பாருங்க. So I see the answer here. So many of you have said that more than 50% of you have said that you will do a posterior capsulotomy with a vitrector before implanting the IOL, and some of you with the vitrector after the IOL, and none of you post-pupillary capture. Okay, good. Thanks for the response. Now, in my like there are advantages of each. So like first, the vitrector, I would prefer the first one, the primary. That's why obviously I have put it as the first, a primary posterior capsulorhexis with an Utrata forceps. See, when you're comfortable in using this forceps, they have a very good control, and you have a very nice smooth surface of the posterior capsule. And once you learn to do a posterior capsulorhexis, it is even easier than an anterior capsulorhexis, and it gives you a very good control. The size management is easier. Of course, vitrector is also a very good way to do. Sometimes the ragged ends, when you put the IOL inside, very, very rarely you can have a tear of the posterior capsule. After intraocular lens implantation with the vitrector, many institutes and many practitioners do this as a first option. It is also a good option. Only thing, when we plan this, see, after IOL implantation, when you do as a second procedure, after you do a PPC, you know the bag status. You're already aware whether the bag is intact and in a good condition, so you can plan a single piece intraocular lens in the bag. Suppose you put the lens inside the bag and you do a vitrector capsulotomy. After you do, and if you encounter some issue and the capsule ruptures or the posterior capsule gives way or something, then you already have a single piece foldable lens inside, and it is very difficult to remove through the opening, so it becomes a little messy. But if you are experienced, all the three options are good, equally good. So thank you for the question. We'll go to the next slide. So this is a small video on how we do the posterior capsule. So the last piece of the cortex is being removed. I chose this video because the posterior capsule is clearly seen. It's a little membranous. So you can make again a small nick with the cystitome. And you can use the Utrata forceps through the main entry, and you can catch with the forceps, and it gives you a good control. Here again, the tip is not to leave. Like in anterior capsulorhexis, it is good to leave to keep catching the edge of the rhexis. But here it is better not to leave the rhexis, because once the vitreous comes and gets mixed with the capsule, it is very difficult to retrieve the rhexis. It becomes a little messy. So after that, you place a small anterior vitrectomy you do, and then place the intraocular lens. So a posterior capsulorhexis is mandatory till the age of 6 years, because we know that the rate of posterior capsular opacification, if we don't manage the posterior capsule, is almost 100%. And the ideal size should be at least 4 millimeters. So like we said, it can be either manual or with a vitrector. And anterior vitrectomy can be done along with an anterior posterior capsulorhexis up to the age of 6 years. So we saw various clinical scenarios where we face a pediatric cataract. It's congenital or developmental cataract associated with anomalies, associated with systemic conditions, trauma, steroid-induced, complicated. Most of it managed based on how dense the opacity is, and depends on all the factors that we just discussed. So these are a few situations we see traumatic cataracts. The upper picture is pre-surgery and the lower picture is post-surgery. The first two conditions we see post total cataract. The first one, we see an anterior capsule rupture with cortical disturbance inside. So after the surgery, we have been able to put a lens inside the bag. So there are other types of other situations where, like we said, associated with the corneal opacity. So here, to overcome the corneal opacity, a pupilloplasty has also been done along with the cataract surgery with IOL implantation. So this was a membranous cataract, what you see there. So the membrane has been trimmed and an intraocular lens has been placed in the sulcus because the capsules were found fused. There was no volume to the lens and there was no bag. And uveitic cataract is again another challenge where the uveitic specialist you have hand in hand, then you manage the uveitis, and cataract is during the course of uveitis management, you face cataract in children. So there are lots of, it's a totally different lecture altogether. The main criteria here is lens, if at all you place, it has to be only in the bag. There is no role of a sulcus lens in a child with uveitic cataract. So we saw situations where we were able to place lens, or where we decided to place an intraocular lens primarily. So what are the situations where we decide not to place a lens inside the eye as a primary procedure? So that situation is called lensectomy. So when do we do lensectomy? When we don't prefer an IOL. So there are very young children in some trauma. I chose this video because it is a very interesting video. We thought first it was a blunt injury. The iris was fully adherent or close to the cornea. We could not even see the anterior chamber. Once after anesthesia only, we realized there was a limbal tear and there was like a iris Bombay. So we made a pupilloplasty. We actually made a pupil, found a total cataract inside. We tried to do a rhexis. Here we couldn't complete because the lens was fully opaque, so we made it with a cutter and removed the capsule. So steps of a lensectomy, a simple lensectomy is a limbal approach is preferred. You make 2 limbal openings at 2 o'clock and 10 o'clock. You do a capsulotomy either with a cutter or a forceps, and a good cortical cleanup and a posterior capsulotomy. Here the idea is to remove the lens and leave a rim. A posterior and anterior capsule rim, the size can be same. So you leave approximately an 8 mm opening in the center, and you have to do an anterior vitrectomy. So if no primary IOL, then what do we do? So we have this unique situation in children, aphakia. So how do we manage aphakia in children? What do we do? So do we implant a contact lens like this child, or do we plan a secondary IOL? So how do we manage aphakia in a child till we are able to implant a secondary IOL? So aphakic glasses, single vision glasses up to the age. If bilateral good surgery done in a very small child, the children do very well with single vision aphakic glasses up to less than at least 1 year. And you have to start giving bifocals after 2 years of age. So you have to always make sure the near vision is corrected in a very small child. You have to address to the near vision. The need for near vision is very important in the younger the child is. And contact lenses, even in bilateral cases, contact lenses have a very good role, especially they're easy to manage. Once you insert, there are extended wear contact lenses, which the compliance is better, the parents in younger age, but hygiene is very important, especially in low socioeconomic groups. You can try to avoid it in bilateral situations. There is a theoretical saying that if you operate a very early age, and maybe wearing contact lenses can prevent the onset of nystagmus, but it is to be tested. And secondary IOL implantation as per age. So unilateral, of course, contact lenses is the first choice. Rigid gas permeable contact lenses or a silicone extended wear contact lenses are used. The insertion is difficult, the management is difficult, but you have to always encourage, and that is the best way to manage a unilateral aphakia in a small child. Very, very rare situation where you are not able to use contact lens for various reasons. Glasses can be tried. And a little earlier, beyond 2 years of age, you can implant a secondary IOL if all other parameters are normal. So once surgery is over, you can't sit back and relax in a child like in an adult. So surgery over, the treatment actually starts. That's what we tell the parents. Like, surgery is only the first step in managing a child with a cataract. So surgery is the first step. So what do we have to do? We have to give appropriate glasses as per age. So infant, like we just saw, single vision glasses for near with +3 add actually, and less than 2 years, single vision glasses for 1 meter distance. More than 2 years, you have to start the child on bifocals. So switching the child to bifocals at the correct age is very important. You can assess the child's visual activity, how active the child is, and start. And amblyopia management goes hand in hand with everything else that we do. An assessment of IOP, if required under anesthesia, as and when required, lifelong. That cannot be overemphasized. You see this happy child with unilateral cataract, nicely patching, wearing glasses. So what is the latest issue? So when we talk about pediatric cataract management, pediatrics is again divided into infant and pediatric and older children. So now this is the hot issue here. Since myopic shift is maximum less than 24 months of age, and there is in a very young child associated microcornea, fetal vasculature, and the surgical expertise which is required to manage a little older child is probably a little more challenging when it comes to younger children, and anesthesia issues are very unique to very small children. So when it comes to infantile and pediatric, we have a lot of differences. So in an infant, how early the surgery should be. So in unilateral cataract, as we said, it is an emergency at any age. So up to 8 weeks or around 8 weeks, we can plan to operate the cataract. And asymmetric cataract, again 8 weeks. Bilateral dense cataracts, we can wait up to 12 weeks if there is no nystagmus or other symptoms and do the surgery. And between the eyes, the spacing should be 1 week. And like we said, secondary effects, if it is there, early surgery is preferred. So now the next poll question is, how early will you implant IOL in infants? Less than 1 year, less than 6 months, and less than 2 months. Okay, I'm actually happy to see the result. We have more than 86% of you responding to less than 1 year, which means very less of you do surgery, put primary IOL implantation in children less than 2 months and less than 6 months. So we still do not have a consensus here. World over, people are, the threshold for implanting primary IOL keeps reducing as it goes. But what actually we should do? So these are the criteria which have to be extremely strict when we plan a primary IOL in an infant. The corneal diameter has to be at least 10 millimeters. Intraocular pressure has to be normal by Perkins tonometry prior to cataract surgery, which is mandatory in all the children. And there should be absolutely absent angle anomalies, which is done by goniometry assessment prior to the surgery, and axial length should be at least 16 millimeters. So this is a very important criteria irrespective of age when we plan intraocular implantation as a primary procedure in infants. So we have this great study to actually guide us, infant aphakia treatment study. The result of 1 year is they studied equal number of children with contact lens and intraocular lens. They found visual outcome comparable between the intraocular lens group and the contact lens group. Adverse effects were significantly less in the contact lens group as compared to the intraocular lens group, which is 77%. And number of additional surgeries required were much higher in the intraocular lens group. And the additional surgeries were required to do visual axis opacification, to improve the visual axis opacification. And intraoperative complications were also slightly higher in the intraocular lens implantation group. And the same group was followed up at the age of 4.5 years. Again, the visual outcome was comparable. Adverse events continued to be higher in the intraocular lens group, though the contact lens group had a increase. This was because of infection related to the contact lens usage. Again, the number of additional surgeries which were required were much more in the intraocular lens group. And glaucoma was found to be comparable actually, and it was not found to be whether because of intraocular lens implantation or contact lens. It was more associated with younger age in both the groups and smaller corneas in both the groups. So what is the take home? Early surgery is always mandatory, but early surgery does not translate to early primary intraocular lens implantation in children. And primary intraocular lens implantation is safe in unilateral cataracts around the age of 6 months and bilateral cataracts around the age of 8 months. Choice of IOL poses a challenge. Steps to prevent capsule opacification is mandatory depending on the age, at least up to the age of 8 years. And timely correction of the residual hyperopia with the near ad lifelong is very important. Amblyopia management, as long as indicated, goes hand in hand with management. And proper timing of secondary IOL implantation, if the child was aphakic, is very important. So thank you. So now probably we can go to the questions. I see some of you could not see the video, and some of you have asked me to repeat the video. If there is time, probably I can do that. Which video to be exact?
Dr. Kavitha,
Yes.
only the first video in your presentation played properly for the audience. The remainder of your videos did not play.
Okay, so
we'll have to follow up. We'll have to follow up after the lecture to see if we can sort that out, maybe by providing a copy to the audience.
Sure. I'll do that. I'm sorry about that. And there is one Dr. Uchena Novoka who asks me the summary of pathogenesis of pediatric cataract. I'm not sure what exactly she wants me to repeat. And her second question is, she wants me to repeat the take-home message. So the take-home is simple, like pediatric cataract surgery, we need to take into all the considerations, and early surgery is mandatory, but early primary intraocular lens implantation has to be taken with a pinch of salt, depending on all these issues that we talked about. And after cataract surgery, correction with glasses and contact lens and for distance and near is very, very mandatory, along with amblyopia treatment. And lifelong monitoring of intraocular pressure and to look for other cataract surgery related complications is very important. So cataract surgery management in a child does not stop with the surgery. So there is a question on PCO management by Dr. Soflane Seidel. It just says PCO management. Like once we do a cataract surgery, we take all the precautions and we can still get a posterior capsule opacification even after a good posterior capsulorhexis. In children, like we said, the cortex, whatever, even if a small few cells are remaining, especially when you place a lens in the bag, there is always a contact which the lens can proliferate. So we can have after cataract called Elschnick's pearls, which can start creeping into the visual axis from behind the intraocular lens or even anterior. So older children, older than even 3 years, do cooperate for a YAG capsulotomy. We have had very good cooperating children who can sit in a YAG in a machine, and we can do a very good YAG capsulotomy if the opacity is thin and early. If it is a thick membrane, children sometimes, because they present late, can have a very membranous posterior capsule opacification. In that case, YAG capsulotomy may not be a viable option. So in that case, we can do a surgery to clear the membrane. Membranectomy we have to do. And a little younger children, if the cataract, the opacification is not very dense, we can do a capsulotomy. But in case they do not cooperate, we have some experience with doing a capsulotomy under a general anesthesia. Here the challenge is to give anesthesia, and under anesthesia we have to make the patient sit up for the YAG machine. So it's a very technically uncomfortable for the child, for the anesthetist, and for us, but it is not it is an option. So we have had experiences in children, capsulotomy under general anesthesia. So PCO management is also as important as managing the cataract. So we have a question from Dr. Mariant Noor Rehma. I'm sorry if I'm not pronouncing the names correctly. How do we manage the visual rehabilitation in children with dislocated lens? Oh, it's a very important question. So I totally skipped that actually. So a group of children with pediatric, pediatric age group present with subluxated and dislocated clear lenses, if that's what this doctor is asking about. So subluxation in children can be associated with systemic conditions like Marfan's, or it can be congenital and it can be hereditary, isolated without any other systemic conditions. So many of these children present with high myopia due to the loss of convexity of the lens, increase in the curvature of the lens. They can present with high myopic astigmatism actually. So initially, if the astigmatism is not too high, they do very well with glasses. But if the visual axis is partly phakic and partly aphakic, then correcting these children with myopic correction may be a challenge, and they will have dense amblyopia already. So sometimes we do not go ahead and immediately operate. We can, if the aphakic portion is large, we can give aphakic glasses with the near ad, and there are a lot of children who do well with this kind of management. So because surgery for a subluxated lens, lensectomy, has very, very high chances of retinal complications following surgery. So we always try conservative method of glasses, contact lenses, and then if not able to rehabilitate, we go in for surgery. And nowadays there are if minimal subluxation, people try Sionis rings and segments, and try to implant IOLs. So that can also be tried if the subluxation is minimal. So there is another question. Do you use intraocular antibiotics at the end of the surgery? No, we don't use intraocular lens for child or adult after the surgery, not at all. There is another question by Dr. Vinu Man. How do you manage amblyopia in post-cataract surgery patients with nystagmus? That's a good question. So nystagmus usually is present in a child presenting with bilateral cataracts. So if there is a clear difference in visual acuity between the eyes, patching, just like any other patching for any other amblyopia, is the mode of treatment. But bilateral subnormal vision due to cataracts presenting with nystagmus also, we just have to give them glasses. There is no role of patching in that situation. So the child has to have a clear difference between the eyes. The visual acuity has to be clearly different between the eyes, and they do very, very well with the patching regimen like any other type of amblyopia. So there is another question by a Dr. Sofain Saidi. Pars plana lensectomy versus limbal approach. Like I said, both have a very good, anterior segment surgeons. Pars plana lensectomy, nowadays pediatric cataracts, even for infants, have come into the hands of pediatric ophthalmologists rather than retinal surgeons. Previously, when it was a treatment, it was taken care of a retinal surgeon, pars plana vitrectomy, pars plana lensectomy was probably preferred, but now it is equally preferred. Limbal lensectomy is probably a better choice. Anterior approach is better in most of the situation, except in very small eyes, very small microcornea, where anteriorly there is no space for us to approach. Then pars plana lensectomy can be done. Otherwise, anterior approach is preferred. So there is another question by Dr. Tara Hassan. How to calculate IOLs for infant? Like I said, the SRK2 or SRKT formula works. So we have same way, under anesthesia, we have to do a keratometry, a good keratometry with the handheld keratometer. And the axial length measurement. So if the corneal diameter, keratometry, axial length. If all the three, like corneal diameter more than 9.5 or 10, axial length is more than 16 millimeters, then you can apply SRK2 formula and calculate lens IOL implantation for even infants. But we here in our institute do not prefer a primary intraocular lens implantation for children less than 6 months of age. That's all.
So to our audience, if you have any additional questions for Dr. Kavita, please enter them now in the Q&A box. We have about 8 minutes remaining in our time slot, so lots of time for additional questions.
There is a new question on multifocal intraocular lenses in children. I'm actually glad you brought it up, even though we are totally against multifocal lenses in children. As we saw through this lecture, see, children, especially up to the age of 10, 8 or 10, have lots of issues with myopic shifts and the challenges in how to calculate intraocular lens power and all that. So multifocal IOLs in children are still highly debatable. Children by whom I mean less than 10 years. In many places, many doctors, they have started kind of unilateral cataracts, and children with absolutely no other problems. They are considering multifocal intraocular lenses in children, probably a little older children, but there is still no standard guideline on multifocal lenses in children. And by principle, we still do not advise multifocal lenses in children, definitely not below the age of 10 years. And there is one more question on minimum age at surgery. Like we said, age, when we mean minimum age is at least 6 weeks to 8 weeks is the minimum age to manage a cataract which is visually significant. It is when we consider primary intraocular lens implantation, all these other issues arise, like 6 months, 8 months. So age of surgery, safe from the anesthesia point of view, is 6 weeks, 6 to 8 weeks for unilateral cataracts, and beyond 8 weeks for bilateral significant cataracts. So how to manage rhexis in membranous cataracts? That's a very good question. So membranous cataracts, there was actually a picture which I had taken. I don't have a video. So membranous cataract, sometimes the membrane is a uniform thick membrane, then we have no choice. We need to use a cutter, we need to use a very good curved scissors and try to make an opening in the center, and with the use of cutter and scissors, we need to try to make a rim where if there is no other problem, you can place the lens in the sulcus. If one of the capsule is membranous, like the video which I'm not sure if it played for you, the posterior capsule alone was slightly membranous. So you can manage it in a similar way like any other rhexis. A capsular forceps, if the membrane is not very thick. Otherwise, if a thick membrane, if you use a forceps, the traction on the zonules is a lot, and it can give rise to problem and stability of the bag. So a cutter, a vitrectomy cutter is preferred. So a cutter, a scissors, curved scissors, along with the forceps should be your instrumentation. Any difference, Dr. J. N. Nath Verma, any difference in post-operative medication between children and adults? I'm sorry, I really forgot to actually mention about this. Exactly. So in adults, probably there is a huge variation of how post-operative inflammation is managed. We normally give a 6 weeks course of tapering, course of steroids, starting from every 6 times a day to tapering. But in children, we have to give a longer term and high dose steroids. So we use 1 hourly prednisolone eye drops for the first week, followed by at least for 8 weeks of steroids in a tapering dose. And in many, we add an antibiotic for 2 weeks, and we use a cycloplegic like homatropin in most of the children. Nowadays, in a little older children, we have stopped using homatropin. So cycloplegia, antibiotic, and 8 weeks of steroids, starting with the high frequency, high strength steroid like a prednisolone acetate. Management of central total opacity with cataract like Peters anomaly. This central total corneal opacity. See, if the total corneal opacity with cataract, probably if the glaucoma is under control, I think that's a corneal, basically corneal management is depending on how dense the opacity is, probably penetrating keratoplasty or anything like that. There was a picture in my presentation where the opacity was paracentral. If there is a paracentral corneal opacity and you still have a good amount of visual access, you can manage while doing your cataract surgery by doing a pupilloplasty or an optical iridectomy to give enough visual access. So this is if it's a central large total opacity, then there is no option. You have to remove the opacity by penetrating keratoplasty or a DSEC, depending on how big the corneal opacity is. But if it is paracentral or if it is a very small opacity in the cornea, then along with managing the cataract, you can make a pupilloplasty or an optical iridectomy, which works very well. And we have a question, Dr. Tara Hassan. How many diopters subtracted from IOL in infant? Up to 8, very small infant. Like I said, we do not operate children younger than 6 months and for intraocular lens implantation, and we use up to 8 diopters. We undercorrect them by 8 diopters residual. And 6 months to 1 year, we use plus 6 diopters, and beyond 1 year, we use plus 4, like that. So less than 6 months, we do not have experience, not much. So how common is glaucoma post-cataract surgery and how to monitor? An uneventful cataract surgery, like in an older children, the incidence of glaucoma is very, very, very less. We had a study in our institute also. The incidence in like a zonular cataract operated more than 3-4 years of age, the incidence of glaucoma following such situations is very less, thankfully. But the single most associated feature for onset of glaucoma is corneal diameter, microcornea, microphthalmia. The smaller the cornea, the incidence of glaucoma following a cataract surgery is quite high, especially if these children, we leave them aphakic. So aphakic glaucoma following surgery in a child with microcornea and microphthalmia. Microcornea, by which I mean less than 8 millimeters of corneal diameter. The incidence of glaucoma is quite high. And how do we monitor IOP? So we follow a protocol of, after the first surgery, we have a follow-up of about 1 month and 3 months. During the 3-month follow-up, we try to calculate the IOP. If the child is not cooperative, depending on the age, we have to give anesthesia or sedation and check intraocular pressure with a Perkins tonometer. And beyond, after that, every 1 year, along with corneal diameter, pachymetry, axial length measurement, and IOP measurement with Perkins diameter and disc evaluation. So this goes hand in hand for invariable of what age the child is up to lifelong. So the younger the child, you need to probably give general anesthesia, but more than 3 years, 4 years children, you can give mild sedation if the children are not cooperative. Beyond that, most of the children are cooperative for applanation tension tonometer. And at what age do we consider sutured IOL? Dr. Ahmad. So sutured IOL, I assume it's a scleral fixated IOL. If it is a scleral fixated IOL, the sclera rigidity and the eye size up to the age of 6, not less than 4 years, scleral fixated IOLs are not recommended in children less than 6 years of age. So they're done for children where maybe following trauma or subluxated lens where we had to do a lensectomy and there is no capsular rim, but it is we have to wait till the age of at least 6 years. I'm sorry, this repeated question on etiology and causes, Manish. Etiology and causes of pediatric cataracts in general, there is a question. See, most of the pediatric cataracts which we see are idiopathic. Like we said, more than 50% of the children come into the category of there is no cause. And the second commonest group is development, congenital, I mean hereditary. Hereditary, again idiopathic. Heredity, it's an autosomal dominant inheritance for pediatric cataracts. But other causes are like associated with systemic abnormalities, torch infection, inborn errors of metabolism, trauma, all those other causes. But most of the pediatric cataracts, more than 50% what we see has no cause, idiopathic.